Welcome to this class on Psychiatric Advanced Directives. For the rest of the presentation, I'll be using largely a person-first perspective, so I'll be using you to refer to either you as providers taking this course or you as potential users of PADS. Today, I'll be going over what is a Psychiatric Advanced Directive, or PAD, when they're useful, why someone might be interested in filling out a PAD, steps towards advocacy, including provider education, patient education and support, and implementation, and finally we'll go over the specifics of PADS in your state. So let's get started with lesson 1 of 3. What is a PAD? As an outpatient provider, your role is to frequently act as an advocate on behalf of your clients, as well as acting as their provider. Advocacy is utilizing one's power, authority, or privilege to help empower another by facilitating the expression and implementation of their wishes. By supporting education surrounding PADS in the community and improving implementation practices, you can facilitate the direct expression and implementation of one's wishes at a time when they are not in a position to advocate for themselves. While individual support for PADS is high, there is a significant disparity between the number of people who want and the number who successfully complete PADS. I really want to highlight that this disparity disproportionately impacts marginalized individuals whose input and desires are frequently unsolicited and ignored in the treatment and intervention processes. If you only take one thing away from this presentation, I hope you learn that the power you as providers hold is immense. Outpatient provider support is the #1 determining factor for if an individual implements a PAD, so it's really important you are able to act as an educator for your clients. Let's start with the basics. What is a Psychiatric Advanced Directive? Similar to Medical Advanced Directive, PADS allow an individual to express their treatment wishes for a time at which they might not be able to do so. PADS are state legislation, so the exact laws for each state can vary quite dramatically. Throughout this presentation, I will highlight some of these differences as case examples. Here you can see an example of the form header for the Georgia PAD. I'm going to start with this example as it's probably one of the most comprehensive PADS in the nation. To take a step back and look at the history of how patient self-determination has evolved, one of the big catalysts was actually One Flew Over the Cuckoo's Nest. This book and the subsequent movie showed people a pretty horrific depiction of the mental health care system and specifically electroconvulsive therapy, or ECT. PADS were initially created from concerns surrounding how someone can put a limitation on ECT, and they've since expanded to allow someone to outline not only their preferences for treatment, but also their symptoms and treatment history in order to give crisis intervention teams a better picture of their patient and which interventions might be helpful. The Georgia PAD was modeled after a WRAP, or Wellness Recovery and Action Plan, so it allows someone to be very comprehensive in sharing their lived experience, including symptoms, effective de-escalation strategies, preferred hospitals, clinicians, triggers, possible ways to intervene before symptoms escalate to a crisis, and support people and their roles. A PAD becomes active the second a doctor determines that you are unable to consent for yourself, and stops being active once a provider has determined that you have regained your ability to consent. Showing some signs of a disorder is not enough to qualify as not being able to consent. The situations where someone might not be able to consent are really going to be limited to severe instances of psychosis, mania, and catatonia. This means that a PAD can be active for as short as a few seconds or potentially upwards of a few months. The nuances of when and how this can happen in the crisis intervention process can be a bit tricky, so I'm going to take the next few slides to give you a 10,000-foot view. Keep in mind that the specifics for each state may vary slightly. When a crisis happens, someone may call 911, and emergency response personnel like police officers and paramedics will do an initial evaluation. During this process, if they feel that you may pose a risk to yourself or others, they can authorize for you to be transported to an ER or short-term facility for an evaluation of competency. Alternatively, a loved one may bring you to an ER or short-term facility themselves. Within the ER, a doctor may decide that you pose an immediate risk to yourself or others and authorize what I'm going to refer to as emergency medication administration. Usually, a social worker or psychiatrist will evaluate your emotional state and decide whether you should stay in a psychiatric facility. This is determined based on whether they think you may harm yourself or others. Depending on the state, you may not have to meet with a psychiatrist. You may meet only with a social worker, and a psychiatrist will sign off approving their evaluation without speaking to you directly. If someone has determined that you pose a risk to yourself or others, you can be held on a psychiatric hold in an acute care facility. In this case, you may or may not have to sign an admission document for your stay in a psychiatric hospital. If your PAD is active during this time, meaning a doctor has determined that you are unable to consent for yourself, you technically cannot sign the admission document. However, many facilities will have you sign anyways for ease of paperwork and procedure. By signing this document, you are voluntarily committed to a psychiatric facility, even if you were told that you had a mandatory hold. If you are asked to sign and refuse to sign, or you cannot consent to admission, then you can be involuntarily committed to a psychiatric facility. In this case, staff are supposed to inform you of your rights, and they need to request permission from a court if they wish to extend your stay. Within this facility, there are daily medications and other treatment modalities used, and then of course there are also those emergency medications that could be administered if the provider decides that you pose an immediate risk to yourself or others. To recap, a PAD is useful for informing which maintenance medications and treatment modalities are used when you have been deemed unable to consent. PADs can also inform the type of emergency medication that is administered within the ER or psychiatric facility, but they cannot prevent the use of emergency medications. Importantly, a PAD should inform the type of emergency medication used if the provider has read through the PAD. So, in a practical sense, this means that it's much less likely that a PAD will inform the type of emergency medication that is used in an ER as compared to an acute care facility. To emphasize this point, a PAD cannot prevent involuntary hospitalization or the use of medications in a situation deemed an emergency by a physician. It can, however, inform the type of medication used. A PAD is state legislation, which means that a PAD cannot be valid in a state outside of the one it is written for, except in certain scenarios where one state's PAD happens to fulfill all the requirements of that other state. So if a client is going to be transferred to, say, an out-of-state residential facility, this is something to consider. At the risk of belaboring a point, a PAD cannot prevent involuntary hospitalization. It is only meant to allow you some say in the type of treatment you receive. And of course, a PAD cannot force a provider or facility to provide you with care that you are unwilling or unable to pay for. Some PADs, like the Georgia PAD, allow you to include a free response section for preferences and special considerations. If your client wants, they can also amend their PAD with more information as well. One of the most important things that PADs do is increase trust in the mental health system. Most individuals that are cautious about engaging with the system have a particular history or experience that they don't want to repeat. Allowing someone to explicitly outline this can be immensely powerful towards earning their trust. One anecdote I have is someone one time had a very distressing experience where they were placed into a room at a facility where a friend had previously passed away. At that time, they were in so much distress they couldn't effectively communicate to their providers, which, as you can imagine, caused them to have to endure a pretty horrible experience. In their free response section, they were able to write that they didn't want to be placed in that room and their reasons, which was pretty self-empowering. Other examples might include dietary restrictions, preferred pronouns, preference for or against religious-based therapy, if someone has limited English proficiency, if someone is okay being transferred to a facility in another state, and which states, and chronic medical conditions. One thing I really try to emphasize is which insurance someone has and if they are okay being treated by an out-of-network facility, and if there are any limitations on the number of days they are okay with. The other thing I try to mention to providers, given my experience at rape crisis facilities, you can explain to your clients at your own discretion. As I'm sure we're all aware, sexual assault is a pervasive issue which does unfortunately happen in facilities as well. If someone currently has an active PAD, meaning they are unable to consent for themselves, they cannot consent to a forensic medical exam or rape kit. However, a PAD is a way to circumvent that. If someone consents to an FME in their PAD, that opens the door to the possibility of collecting evidence within the limited time frame it exists. The nice thing about this is that someone can always verbally dissent to a kit. This means if someone consents to a kit in their PAD but doesn't want one at the time, then no kit will be performed. Before our next lesson, you'll take a quiz reviewing what you've learned so far.